Good afternoon, everyone. Just the mic. Good afternoon. It's not working.
It was when you first picked it up.
Usually I don't need a mic, you know. After raising two children when they're teenagers, you don't really need a mic. You know, you learn to project your voice very well. So thank you all for coming, and welcome to the IDGR pulmonary version of the FYI series. For those of you who don't know, I'm Ethel Kagan. I'm the Assistant Director in the IDGI group. And thank you, as I said, thank you for coming. I do want to make, I do want to acknowledge a couple of people before. First of all, Antoinette Glover, who really worked on organizing this, and certainly there were other people in terms of an organizational team behind this. But Tony did a lot of the legwork on this, so I really want to thank her for taking charge of this because I didn't have time. So before I introduce Dr. Tillman, I just wanted to kind of give you a little overview of some of the exciting topics that we're going to have, and topics that are very timely. So today, of course, we're going to talk about hepatitis B, but I also wanted to let you know that in October, we're very lucky. We're going to have Dr. Brian Smith. He's going to talk about neonatology. Part of what we do, if you don't know, and Catherine Beresny is the project leader who does a lot of this, is we also do infectious diseases in pediatrics and actually in neonates. So he's going to talk about challenges of trials in the smallest patients. Because you can imagine, I think some of them are, what, 250 grams, these things? You can, you know, hold them in one hand, and we're actually doing clinical research with them. I think very timely is Emmanuel, actually everyone calls him Chip Walter, is going to talk about in November the H1N1 virus. So I'm sure for that one the room will be full. And actually he is actually a site for the vaccine trials that are going on right now. So it's going to be very exciting to hear it firsthand because he's actually working on the vaccine trials. We also have Alex Thompson, who's going to talk about hepatitis C. And for those of you who don't know, and Hans certainly can say this much better than I can, but Alex, along with others, and under the leadership of Dr. John McCutcheon, actually did discover a piece of a gene which helps determine which patients who have hepatitis C genotype 1, which of those patients would actually benefit from treatment and which wouldn't. So this is actually was in Nature magazine. So again, this is very, very timely because it's really, I mean, they're actually going to be going at, they've actually been invited by the FDA to come down and talk to the FDA and help the FDA figure out how this is going to affect not just clinical trials, but clinical practice. So we're really very fortunate. Vance Fowler is going to talk about bacteremia. Susanna Nagy is a new member of the faculty. She was a fellow here, and her expertise is in HIV. And for those of you who don't know, the next phase of clinical trials in hepatitis C are really going to be in HIV-HCV co-infection, and that's really an interest of hers. So again, and I thought that would be really interesting to have somebody talk about general bacteriology. You know, many people are kind of come from other groups, work with us. So I think it'd be fun to have a general bacteriology talk. Dr. Sunday's going to talk about asthma. We had to do something for those poor pulmonary people. And Dr. Michael Cohn, who's also a pediatric member of our faculty, is going to talk about pediatric rashes. So I think we have a very interesting program. So does anybody know how to use that? I have to tell you, I'm not the technology queen. You know, my children, especially my son, makes fun of me. So without further ado, I want to introduce to you Dr. Hans Tillmann. We're very fortunate at the DCRI to have, I don't know if we kidnapped him or we just begged him to come to the DCRI. He's really a world-renowned expert in hepatitis. He's done a lot of work in hepatitis C, especially for those of you who are currently working on some of our trials on HCV RNA monitoring. and he is a professor in the Department of Medicine, and I've been very lucky to be able to work with him this past year and a half. So without further ado, Dr. Tillman.
Oh. Yeah. Thank you. Yeah, Ethel and I, we have a link. My wife is actually from Montreal, and she was working for now for 10 years for Abbott Diagnostic, and we met on a conference. And I just settled in as a full professor in Leipzig, here in the eastern part of Germany, which is historically pretty interesting because it's really the place, and there's a church where I would say the reunification started, with people standing on the street and saying, we want freedom, we are the people. And there was one day where people were sitting in their tanks ready to go, similar like the Chinese solution, and there were people on the street who were very brave. I was fortunate enough to live in the West and not being exposed to the communist system. But meeting those people has been really an interesting time. But then I met my wife, and she was working in the US, and I know John McCutcheon, and we were talking, and I was just got engaged and told him about that, and then he said, "Oh, that doesn't sound like a good idea. Chicago, Leipzig, and it's really indeed not very comfortable." And so now that brought me back, or brought me here to the US now. And with this, I would present some data on hepatitis B. And let's start with a landmark paper, because I think hepatitis B is so interesting in many aspects. But one of the things is that the landmark paper for hepatitis B is actually titled "A New Marker for Leukemia." And why I bring this up is that science is always so interesting. You must not stop too early, yeah? Because it was actually that this guy, Bloomberg, he was awarded the Nobel Prize for discovering this an initially believed marker for leukemia, which turned out to be the hepatitis B virus. And certainly the other guy, specifically Harvey Alter, is very well known because he was also instrumental later in identifying hepatitis C. But yeah. What I think is the main take-home message for the talk probably is that we have, as liver doctors, always concentrated on the liver enzymes. And we have learned that the liver enzymes in hepatitis B are not really that relevant compared to the importance of viral load. And the other important thing is that I think no one has to die from hepatitis B.
Joining conference.
Unless they develop a tumor.
Moderator features. Would you like your participants to be able to unmute their own lines by pressing *6? Press 1 for yes and 2 for no.
I think we can...
All participants have been muted. You will now rejoin the conference.
So I think disease can be ameliorated in basically everyone, and we will discuss what is the best issue to that. And then we even now know that we can achieve HBs antigen clearance in some. But going more on a systematic scheme, I would start with some things on regard to epidemiology, because that tells us what are the people we should screen and what are the people who we might consider for treatment, because certainly not everyone might need to be screened and not everyone needs to be treated. Once we decide someone needs treatment, the next question is then how do I do the treatment best, and then perhaps a little bit whether there are different approaches for different patients, so whom to treat how. The hepatitis B virus is a little virus here. It comes in a very interesting form that there is, you see there is, these round particles are viruses, and the virus is surrounded here by a lot of different structures. And we know that unlike other viruses, the hepatitis B virus swims basically in the bloodstream in a fog of S antigen. So it gives the immune system a lot of proteins to work with, and hiding in between. It's like in in these fantasy films where you have 1,000 drones and one soldier. Yeah, so then it would be very difficult for the attacker, in that sense, the immune system, to know who is really my enemy. Is this the enemy or this?
Joining conference.
And we know that there are different forms of disease. It can lead to fulminant hepatitis, and it can lead to liver cirrhosis and liver cancer. And it's fortunate probably for hepatitis B that it is so closely related to HIV in its replication cycle. It's the only human DNA virus which uses a reverse transcriptase step. And basically all medications we are using were derived from HIV medication. The only exception is entecavir, which is one of the substances which was initially developed for herpes treatment. And it wasn't further developed and for herpes, and it works for hepatitis B very well, as I will show. But it's very interesting, the replication cycle. I will show this a little bit more. The other issue is that the virus is a very complex virus. It's only having 3,200 amino acids, and to make most out of the amino acid, the virus or the creator of the virus has adapted a system where one genome is coding for different proteins. So like if you have here the polymerase which makes a next virus generation, this genetic information also codes for the S antigen, which is very unique and is something you need to consider if you do something to the polymerase by treatment patients. They might develop a mutation within the polymerase, and this mutation in the polymerase would then frequently also lead to a mutation in the S antigen, and then it can either escape or do other nasty things like staying in the cell. It has basically, there are 4 different aspects. It has an envelope, which is surface antigen, and then to make things complex, you would think there is an E antigen, which you would think might be envelope, but no, the E is for early antigen, and the E antigen is also coded here from the core protein. So it's also something which obviously the virus uses because it's not part of the virus, but it's used probably for the immune system to evade. And certainly the polymerase, which is important to make viruses. And then one factor where one doesn't really know too much about it, but it seems to be involved in carcinogenesis in it. If we talk about hepatitis B, we need to know how we usually should diagnose it. And we have a couple of different assays available. So we can detect the HBS, so the surface antigen. We can detect the HBe antigen, that's the early antigen. And we can detect a couple of different antibodies against anti-HBs, anti-HBc. Then we have anti-HBc IgM, which tells us more, is it an acute infection or is it a chronic infection? And antibodies against the hepatitis E early antigen. Nowadays, a lot of focus is on quantitative HBV DNA because we know now that this is the most important aspect of hepatitis B. We sometimes are interested in the sequence, and there is a certain interest in hepatitis B genotypes, and I will go into that a little bit, in which aspect that might be important. For diagnostic algorithm, we usually do that we do HBs antigen testing, but another alternative would be to start with anti-HBc screening, because that's basically everyone who was ever exposed to hepatitis B and everyone who is currently infected with hepatitis B has this kind of antibody. And there are situations where you also want to know whether someone has a past infection. One of the reasons is that people who are anti-HBc positive with past infection have already a higher risk of developing hepatocellular carcinoma, which one might need to think about. Next step is then that you determine
Joining conference.
whether someone is HBs antigen positive, and then you want to know is if that is positive, you would go into this direction. I think somehow the positive sign disappeared. So if HBs antigen is positive, you want to know the E antigen status, and you want to do the viral load. And if someone is HBs antigen negative but is anti-HBC positive, you want to determine the anti-HBs titer. Because if you are anti-HBs positive and anti-HBC positive, you had a past infection and have pretty good immunity. If you only have anti-HBC, you're probably more likely to get a reactivation during the course of infection. That's perhaps also something which I should indicate. Probably anti-HBC always persists per life because the virus always persists per life. So if you ever had hepatitis B, unlike in HCV, if you ever had HCV, we believe if you
Joining conference.
If you successfully treat it, you clear the infection. In HBV, the virus remains in the body like herpes viruses. Yeah, the herpes viruses remain in the body and can reactivate during the time course. How does this usually look if you get an acute infection? You get a rise in HBs antigen, and almost as far as it increases, it comes down. Again, it's usually perhaps a little bit slower than the increase. Associated with the S antigen is then that you also develop the antibodies, initially both anti-IgM and a little bit later anti-HBC. And then the infection usually clears, the E antigen disappears first, then the S antigen usually clears. And an interesting part is that the symptoms usually start when the virus is already declining. Yeah? So that's why it's very interesting to see, does it make sense to treat someone in the acute phase of the disease? And there is some argument whether it makes sense or not.
Joining conference.
Of course, the symptoms are already, or when the symptoms come in, usually the disease is, or the infection is already coming down. Eventually, when the S antigen is lost, you eventually develop anti-HBs, and that is then a good marker for acute infection. In many people, however, we are not so fortunate that they clear, it becomes chronic, and then you usually have HBs antigen detectable long-term, and in many people E antigen persists for life. In some people it goes away, and I will show some data which indicates that the E antigen is a relative important marker. Where is HBV transmitted? When it comes to epidemiology, it may make sense to think about what is the way you get HBV. Worldwide, the best way for the virus to be transmitted is from mothers to children. And I will show a slide where you see that the chronicity rate in newborns being infected by their mothers is about 90%. This can more or less completely be blocked nowadays, usually with vaccination, if you give active-passive vaccination. In very high viral load, you might also need an antiviral in addition to that. But that's usually in Asia and Africa the mode. The mode of getting infected in the Western world is usually inappropriate contact with people you don't know well enough for the closeness of the contact you choose to have with them. It's sharing needles and working as a healthcare professional with patients. It used to be the most frequent profession-related disease before vaccination was available. So nowadays, everyone should be vaccinated, and so that's less an issue. For the United States, being an immigrant country, it's very interesting that the estimates on HBV prevalence are very difficult to get. Some people believe that the number of infected people have declined over the last decade because most children get vaccinated. People at risk living in the country are vaccinated. But others believe that actually the prevalence has increased in this country. And that is because we have a lot of immigration coming out of Southeast Asia and out of Africa. And if you estimate something like a 10% prevalence, and you consider that alone China, I think, is immigrating 100,000 people a year, that makes 10,000 new infections alone from China every year coming into the country. And then you have all the other countries here in Southeast Asia and certainly also in Africa. So there will be a lot of people coming into this country with HBV. What one also has learned that there is a very good close link between where the hepatitis B is most prevalent and where the incidence of hepatocellular carcinoma is very prevalent. It's not a complete match, but you see it looks very, very similar. And things like here where there is a white blank, that's because there is no data available and not because HCC is not occurring there. No? So we need to consider that HCC is really something which is one of our major concerns, which is not very well treatable at this point. Another way to put it into perspective is if you consider HCV in comparison. So HBV is about 350 million people, and HCV is somewhere between 130 and 70 million people. One sees that how difficult it is to estimate is the most recent WHO scientific estimate was more in the range of 130,000 and published in 2004. But if you go to the WHO website, they say 170 million and refer to the source from 1999. So it says, shows you that the WHO estimate is lower, but they believe it's higher. It's probably similar for HBV, where the rates are believed to be somewhere between 350 and actually 400 million people. On top of that is that probably a third of the world population has been exposed to hepatitis B. So that is important if you consider someone coming as an immigrant to the country and need tumor treatment. They need to be checked for hepatitis B, yeah, because they have a chance of having hepatitis B and getting a reactivation. The other interesting aspect, if you compare these two diseases, it is that the rate of deaths due to HCC seems to be pretty much matching the prevalence data. But if you look to deaths due to liver cirrhosis, there obviously HCV seem to be more aggressive. Yeah? So, but nonetheless, a lot of people dying every year from hepatitis B and hepatitis C. So it's certainly something which is worth looking at. This is now what I indicated earlier, and it's taken from the CDC side, the prevalence or the rate of chronicity when you get infected. Yeah? And you see very nicely, if you get infected newborn, it's about 90%, while if you get it in adulthood, it's more significant, less than 20%. The estimates are somewhere between 5 and less than 1%. So it's usually because it's in most people that they cure the infection, it will be very difficult to get really good estimates on that in the future. So certainly there is a lot of recommendation on whom to screen, and this is here taken from a consensus conference in where I come from, in Germany. We don't do guidelines that we say 2 people now write up what everything is, but do a scientific review and then get everyone in the room and say, do you agree or do you disagree with that? And so for this, which helps people to understand that even experts don't agree on everything. So you see that here 3% did not agree with that this is a complete list, yeah, or find either that this is too much or too many people to be screened. What probably is important to think about as a take-home message, whom you really need to screen, is probably patients before and during immunosuppressive treatment, because that is probably where we see the most deaths nowadays. People dying from hepatitis B because they have an underlying hepatitis B and they get infliximab or rituximab. Rituximab is actually the worst in the sense of getting reactivation. So that's why these people always need to be screened, and certainly if it's an immigrant, it's even more so important. Then certainly everyone with elevated liver disease, and as said, immigrants and the first generation descendants of them. Yeah, because frequently people of Korean descent born in this country still have the mother-to-child transmission risk. So for immigrants and descendants. And then because HBV is so nicely transmittable, yeah, even without inappropriate contact, close contact to people you don't know well enough, you can get HBV. That's why every household member and family members of people with hepatitis B should be screened and then vaccinated. What's working usually in industrialized countries also very well is that everyone who becomes pregnant gets screened for hepatitis B, and that is because it's so effective. You can block the infection basically from mother to child transmission, and that's why every woman gets screened for hepatitis B. And that actually is something which usually isn't taken as a source for epidemiological surveys, because it would indicate you where are the most patients with hepatitis B in a country, and also whether there's a trend of increase and decrease. And I think that's something where we probably should try to get those data for the future better. And certainly newborns need to be tested for HBs antigen from mothers who are HBs antigen, and even from mothers who are isolated anti-HBC positive. That is something which is usually not done. It's not done in where I come from. To my knowledge, it's not done anywhere at the moment, but just timely for the presentation today. 2 days ago, they published a report in where mothers who were anti-HBC positive alone actually transmitted HBV to their children. None of the children became chronic because they were active-passive vaccinated. But that certainly only works if you give, they were actively vaccinated. So an active vaccination probably does not prevent the infection, but helps you to cure the infection in the newborns. So that's an aspect to think. So whom we screen here, it's probably clear the immigrants from areas with high hepatitis B prevalence, and that's the Pacific Island, Asia, and Africa. And Alaska natives have a very high prevalence. And they seem to have a very nasty genotype, which does higher tumor rates. And certainly, I'm like to drink wine, and so you want to think about what do you advise to your patients. And it's unfortunately pretty clear that drinking alcohol more than 67 grams increases the risk of having bad outcome and bad liver disease, increases the risk substantially. Certainly the problem is with those studies that they lump too much together, because 0 to 67 grams, I don't believe that 67 grams a day would be a safe margin. Yeah. So you, yeah. Yeah. So 67 grams is about a bottle of wine, so 0.7. So you don't want your hepatitis B patient. That's a problem with all studies in liver disease, that they usually overdo it. It's probably, they take probably the German approach for alcoholic. What is an alcoholic? Someone who drinks more than his doctor. Yeah. And probably then they build in a safety margin, and then it's 67. It's just that's not really the helpful message, but it seems to be that that's really something nasty to do. And the other aspect here is that if you have a co-infection with both viruses, hepatitis B and C, then you also do worse off than if you have either alone. So that makes sense that one tries to prevent it. The other thing is that one has seen there is something very good, and that's actually why Bloomberg, even though he initially thought he had a marker for leukemia, got the Nobel Prize, because he very early identified that this is actually the protein is usable as a vaccine. And you can see in the HCC incidence that the incidence of hepatocellular carcinoma in children born in Taiwan has significantly been decreasing due to the invention of vaccination. And I know many people probably know that HPV vaccination claims to be the first tumor vaccine, but that's wrong. The hepatologists have been leading the field. Yeah, hepatitis B was the first tumor vaccine available. But I must confess, I wasn't involved in that. But what we know is that reported cases of acute hepatitis, yeah, so not the immigrant who comes with a chronic hepatitis, but acute hepatitis B cases are clearly on the decline. One is probably thankful due to HIV. People with high risk behavior became a little more careful what they do. And then screening of pregnant women, and then universal immunization and adolescents immunization have brought these numbers down, and there is a constant decline in the numbers of acute hepatitis B. Now the question is whom to treat. So this is a study, 30-year follow-up on healthy blood donors with hepatitis B and patients with, people without hepatitis B. And this clearly makes a point, not everyone who is HBs antigen positive needs treatment. Yeah? Because you see, there is no difference in overall death rate and liver-related mortality. So not everyone needs treatment. We know already for more than 25 years now that people who have a hepatitis B and a cirrhosis, they need treatment. There is no discussion about that. Unfortunately, in that time, in 1984, there was no treatment. We also know that people who have, which was then called chronic persistent, or one would say histologically inactive disease, they do very well, while those with chronic active disease do not so well. But with cirrhosis, there is no question. You see, in 5 years, you have a 50% mortality. That is, I don't know any other liver disease which has a 5-year mortality, 50% mortality rate in this short time frame. So for this aspect, it's very clear that if you have someone who is HBs antigen positive, the first question you ask is if he has a liver cirrhosis. When he has a liver cirrhosis, it's clear they need treatment. And then the next question is virus detectable? And then if virus is detectable, treat with nucleosides. And there's disconsensus about what you do with those who have a HBs antigen positive liver cirrhosis and no detectable viremia. I would say I would treat them. There is no risk associated with treating them. And just anecdotally, I have seen people who improved in their liver disease despite not having detectable viral load. But that's not something which is really well controlled. So that's why many people say, I think it doesn't come out well, that one should monitor those every 3 to 6 months. I would think if you have a cirrhosis, you should be treated in any case. So most of our patients we see, though, don't come in and present, unfortunately enough, with a liver cirrhosis, but fortunately enough, they are in an earlier stage. What are the other markers? We know that people who are E antigen positive, they have a much higher risk to come down with problems than people who are HBs antigen positive and E antigen negative. But still, the S antigen positive patients also don't do too well. This has now recently become even more evident that in the E antigen positive population, this is a study in E antigen negative patients, that sorry, that the viral load is really the driving force. And this is really a shift in the paradigm of how we see liver disease. Because you see here in yellow are the patients with normal transaminases. And you see here the people who have high viral load, in that case defined as more than 10 to the 6 copies or 200 international units, 200,000 international units. Even if they have normal transaminases, they have a higher risk than any of the people with elevated transaminases and 100-fold lower viral load. So the viral load is more important than the transaminases. If you're a little bit familiar with hepatitis C, you might wonder, why don't we see that in hepatitis C? Why are so many people saying the viral load in hepatitis C is not relevant? It's very easy. It's probably relevant. But the problem is that your range of viral load is probably somewhere between 10 to the 4 and 10 to the 6. So you have a much narrow range of viral load, and it's actually the bulk of patients lie within 1 log range. So you don't really see much of this variation as you see with hepatitis B, and that's probably why you don't see an effect. What one also has very clearly seen, this is a cirrhosis development. And you see that those with a high viral load, they have a 40% chance of developing a liver cirrhosis within 13 years. Yeah? So someone with a high viral load, in most instances, will need antiviral treatment. And the belief, would antiviral treatment make a difference, is very nicely seen here in this patient, in these patients where you perhaps concentrate on those who were initially more than 10 to the 5. Yeah? You see that if you had initially more than 10 to the 5, if you then later have less than 10 to the 4, you have an increased risk compared for those who have a low viral load initially. Yeah? But you still have a much lower risk to develop complications than those who remain on a high viral load. So that would give epidemiological evidence why you think you would want to treat those people. Another evidence comes from studies where people have, in one study, it was seen what is the mortality in people who are suppressed on antiviral treatment and who are not suppressed on antiviral treatment. This study wouldn't be feasible nowadays because you can basically get everyone undetectable. There is not any patient who should not become undetectable. And this is the people who were suppressed, and you see they have a very good survival, while those where you couldn't suppress the virus have a very bad survival. And similar data were here where you see the rate of complications. The rate of complication is really put significantly down if you treat the patients. Yeah, it was, they had already cirrhosis to start with. That's why you couldn't prevent everyone from progressing, because at some point the liver disease progresses on its own. So what would be treatment criteria here? And this is a recent guideline from the ASLD, the updated guidelines. I don't agree with them. And for this point, you see, in the e-antigen negative patients, yeah, they usually say the cutoff of 2,000 international units, while in the e-antigen positive patients, they would always say only if there are more than 20,000 virus copies. If I consider that the viral load is a risk factor, if I consider that e-antigen has been shown to be a risk factor, there is no reason to treat e-antigen positive patients different than e-antigen negative when it comes to viral load. An issue is, though, you probably don't see anyone with less than 20,000 international units because the e-antigen positive patients tend to be higher in their viral load. Anyhow, the transaminases here were still said to do, if the transaminases are normal, you would just follow up those patients. I would actually think if I withhold treatment in someone with high viral load, I want to have a biopsy. to know that I'm really doing the right thing. And that's actually what the European guideline and the APASL would suggest to do. But the American guidelines say if they are low in transaminases, independent of the viral load, keep monitoring. It's probably neither is completely right, because the issue is probably pretty complex. In the young people, I probably would say that the American guidelines are the correct ones, because if you have someone who is 20 years, has a high viral load, they still have a very high chance of spontaneous clearance. And we know that complications of the disease usually come mainly in people over the age of 40. So you still have time to monitor there. Yeah, I think there you need to consider also the age of the patients. In e-antigen negative patients, it's a little bit different, that they say if you have elevated ALT and a high viral load, you then always go to treatment and perhaps do a biopsy. While if they have normal transaminases and a low viral load, you would continue monitoring. And that probably makes sense, that you say if they have a low viral load and have normal transaminases, you monitor them. But that's probably also for the e-antigen positive patients. So, and that's, as I said, it's clearly seen that e-antigen is a risk factor, and therefore I don't see any reason to allow a higher viral load for them. So how do I treat these patients? So if they have no liver cirrhosis, yeah, the next question I would think is, do they have a high viral load? Yeah, because and that is independent. I would say independent of the e-antigen, and I have not yet find anyone giving me a good explanation, even though I asked the people who wrote the guidelines, why do they want to persist on the 20,000 when e-antigen is a risk factor? But it's don't know. So I would suggest if they have more than 2,000 copies, then you come here, more than 2,000 copies. Then you look into, are the transaminases elevated? If the transaminases are not elevated, take a liver biopsy, and if the liver biopsy shows significant activity, then go on to treat. If they have either no high viral load, I would suggest to monitor them. If they have elevated not elevated transaminases in the setting of elevated DNA, I would think then is the next step to consider, do they have a risk for hepatocellular carcinoma? Because that would be also one of the reasons why you want to treat someone. Yeah? So with a family history of HCC, you want to treat those people. Then the important question is, how do we do that? Basically, you can split the treatment into two lines. You have pegylated interferon or standard interferon, which is very well known to cause a lot of side effects, and patients usually don't like it very much. But the issue is that you have S-antigen seroconversion, and there was just a paper coming out, or it's in press now, which shows that in genotype A patients with less than 10 to the 9 copies, you have a 53% chance of sustained viral response, not necessarily as clearance, but sustained viral response. So this is certainly something you want to consider, because otherwise the patient prefer the pills. They are much more convenient. They don't cause side effects. They have the problem that they need to be taken for years. Yeah. That's something which people don't like so much. And disease is ameliorated in everyone unless you develop resistance. But the issue is, we basically, with the new medications, we don't see resistance anymore. I will show that. So who would be a candidate for this uncomfortable treatment with hepatitis E antigen? It would be a genotype A patient, probably an E antigen positive, probably if the viral load is not too high. You, on the other hand, want to have immune activity and certainly no contraindication. And we have shown in a meta-analysis that up to 20% of those people clear S antigen after just a 1-year treatment. And you probably can even take a shorter time course, probably half the dose for 6 months. The data will probably present it next year, but I would expect that half the dose for half a year will be enough. For the oral antivirals, you would need to know there is resistance barrier and antiviral potency. So if you drop all replication to 100%, yeah, on one day, there would be no chance to get resistance. Yeah? On the other hand, if you have ongoing replication, but you have a high barrier to resistance, in the sense that you need multiple mutations, you probably also be good off. We have now 5 treatments licensed. Lamivudine is the first one, which I think in this country doesn't have any role, because it's almost as expensive as the other treatments. I don't know why that is. In Germany, this is probably 10% of the other drugs. And if it's 10% cheaper, it might make sense to use it for people who have a low viral load. But because it's as expensive as the other drugs, there's no reason. Yeah? Likewise, adefovir. Adefovir is a little bit like the poor brother of tenofovir. It's more expensive, it's less active, and it causes more resistance. Yeah? So it's very easy. They don't have any role. Yeah? They have just no role. So basically, it brings you down to 3 different companies, but 3 different drugs too: tenofovir, telbivudine, and entecavir. And telbivudine could have an option if they would be cheaper. Yeah? But there is no reason to use it, because it doesn't give any incentive. Yeah? So the rate of resistance in entecavir is 0 during the first and second year, basically, and it's 1 year during the third year. Nothing is known concerning tenofovir resistance, so no one ever has seen resistance against tenofovir. So these 2 substances are just excellent, perfect drugs, and there is no place actually also for telbivudine. So basically the treatment comes down very easily. Do you use interferon? If you don't use interferon, you then use either entecavir or tenofovir for your patient. So that made our life very simple. And the other thing which is nice, that there is relatively little overlap in the resistance profile. And another interesting aspect is when, as I said, you use either entecavir, and these colored points show the different resistant pattern which is seen, and here tenofovir. And you see here where there is something that tenofovir seems to be less reactive, that's not cross-reacting with entecavir. Where entecavir does a resistance, there is no cross-resistance to tenofovir. So probably with these 2 drugs, you never go to see a patient really failing treatment. Yeah? An issue is people who had already had lamivudine. They come already in with resistance, with some form of resistance to entecavir, and then eventually develop resistance to entecavir, but they can then still be treated usually with tenofovir. That's from the resistance point of view, but likewise, if you look for the efficacy of the drugs, it's basically, it comes down to these 3 drugs, and you see the top 2 are entecavir and tenofovir, and there is, as telbivudine is not cheaper, there is no reason to use it. Yeah? So it's actually, I think telbivudine is more expensive than tenofovir. Entecavir is the most expensive one, but you can cut it in half. You only need to take half a tablet if you are treatment naive and takes a higher dose. It's on the market in 0.5 and in 1 milligram. And the cheapest way, the company wouldn't be able to promote it. But you still can do what is reasonable. Like people who can't swallow, they would need to have their tablets cut in half and crushed anyhow. And we know that's working. So the cheapest treatment you can offer your patient at the moment is actually giving the higher dose of lamivudine and cutting the tablet in half. And I think there are even tablet cutters on the market so that it works perfectly. That this is then a little bit, if you put potency and genetic barrier into one issue, it is that the interferons have probably the highest resistance to resistance. Interferon isn't any better than PEG interferon. PEG interferon is actually more active and it's more convenient for the patient, so interferon doesn't have any role. Adefovir is a worse from tenofovir. It's less active, has more resistance, so there's no place for that. And entecavir and tenofovir are really the two ones you want to go for, unless you use pegylated interferon. Pegylated interferon has the advantage you give it for 6 to 12 months. All the other treatments at the moment are considered for indefinite because we don't know when to stop. And we know this is a study in transplanted patients that where we were able to show that if people drop with a S antigen by 2 logs, they eventually all become HBs antigen cleared, unless they develop resistance. So these patients here, this one didn't achieve a 2-log drop reduction and therefore didn't clear, and the other ones here, they developed, unfortunately, then resistance and therefore didn't clear the virus infection. This is another thing which came up, but is probably would only be needed for the weaker drugs, that you have a little bit of a roadmap concept. You check after 4, 12, and 24 weeks how well someone is dropping. Probably with some very potent drugs, you now can go only to 24 weeks and then check whether someone has an inadequate response. It might be someone got transfused or infected with a resistant mutant. Then you would add a second nucleoside. If someone has a good response, you just continue. If someone has an incomplete response, you would monitor. So in summary, I would say PEG interferon is still the best drug for the ideal patient, but has problems with that patients usually don't like it. With a highly efficient antivirals, there is very low resistance. Long-term therapy is required in NUCs, and I think we need in the future HBs kinetics to monitor our patients, because everyone becomes HBV undetectable, and then the patient get less motivated if he doesn't see any effect of what he is doing, and that is where S antigen will be good for the future. Is there anything good we can offer our liver patients in general? And this is, I usually don't end any liver talk without coming to this. This is an interesting study, and it has been shown now also for hepatitis C in the HALT-C trial. They have confirmed that assumption. You see here are people who drink up to 40 grams, which is a little bit more reasonable. Yeah, it's probably 0.4 glasses of wine. So in American standards, it's 4 glasses. In European standard, it's 2 glasses, because we usually take bigger glasses. Probably we would feel too bad with our alcohol consumption if we measure it in 4 glasses today. Yeah. But you see that here is the risk to develop liver cirrhosis in people who have a moderate consumption, yeah, which would fit, if you are my patient, would fit this setting that you're not alcoholic, yeah, because it's probably, I lie within this range. If you're here, you would already be in the alcoholic range, and certainly if you're over 80 to 120, then you definitely be in the range. And you see that the risk of cirrhosis dramatically increases if you have this higher amount of alcohol. And what's very interesting, you see this is the alcohol amount, and then this is cups per day. So that doesn't mean how you distribute your alcohol, whether you drink it in 4 cups or in 1 cup. Or this is another drink which you have to take, and that actually is coffee. Because if you drink coffee, you see in the high group, you basically cut your risk in half to develop a liver cirrhosis. So you can't tell your patient, come on and drink, just add coffee to it, because you see a drinker still with a lot of coffee has a higher risk than a non-drinker not drinking coffee. So drinking coffee doesn't counterbalance, but it helps with it. So what are the general recommendation? Not more than 1 drink a day, don't smoke and drink coffee. But certainly with a 1 drink a day, it, the amount would matter.
Are there any questions?
So is it generally accepted practice to genotype a naive patient before starting them if you fear that they've been infected with a lamivudine-resistant type virus?
Yeah, so probably the trick you probably have to play is to say, before I would start any treatment, I want to know whether they have any resistance. And with the resistance testing, you usually get the genotype too. Because I think it would be probably not really reimbursed at the moment if you say, I test for the genotype. But to exclude resistance, that would be feasible. And it probably depends, and like if you have an Asian patient, they're very unlikely to be genotype A. If you have someone more of European descent or European immigrant with hepatitis B, they probably should be tested. In an ideal world, I would think everyone should be tested for their hepatitis B genotype because it is just very effective in genotype A patients. And I haven't shown the data. It's quite interesting if you look to the. They did Wash did a 24-week dose finding study, and didn't understand the kinetics of hepatitis B on interferon probably, because they looked at the end of treatment, and then developed their phase 3 study on that. And at the end of treatment, the 180 microgram, which was taken for the phase 3 study, is the most effective. But for interferon, you usually measure 24 weeks after end of treatment. And 24 weeks after end of treatment, actually the 90 microgram, so half the dose, was the most effective. And actually the 90 microgram, 24 weeks, it was more effective than in the phase 3 study, the 180 over 48 weeks. Certainly problem is one has very little patients, one has a lot of patients, and it took them, I think, 5 years to postpone coming out with the results, which they were now forced to do. Cut the dose in half, cut the treatment in half, and compare that to long-term high-dose treatment and see what the effect is. But yeah.
How long can a Hep B virus survive outside the human body, and how's that compared to Hep C virus?
That's a very good and important question. Hepatitis B is unfortunately extremely nasty in that regard, and one estimates that even after a week it's still infectious. Unlike hepatitis C, which probably gets inactivated within a few hours, and HIV likewise in a few hours.
Yeah, I can tell you that when I was doing infection control and we looked at hepatitis B positive hemodialysis units, and we cultured things like telephones, inanimate objects, we really found a lot of hepatitis B, and that's why you know, when I look at that curve, I can tell you I was on the left side of the curve. I started doing it in 1974, and I can tell you that we had a lot of trouble convincing hemodialysis nurses not to eat in the unit. Same with lab technicians, not to eat in the unit. And so we did actually culture the surfaces and really found that hepatitis B, you know, you find it on the telephone. You just basically find it everywhere. So we definitely implemented a lot of the, and I remember before OSHA, way before OSHA, trying to convince hospitals, administrators that it was cost effective to actually vaccinate, as soon as the vaccine came out, to actually vaccinate all the employees who had, you know, housekeeping people who got stuck, who would potentially get stuck with needles. You know, imagine OR nurses. I can tell you, as a student in the 60s, when I worked in the OR as a student nurse, when the surgeon didn't like how you scrubbed, they would, or circulated, they would actually throw a bloody sponge at you. So that practice actually waned after people recognized this. Hans, when you talk about neonatal transmission, are you talking about maybe to clarify, is the transmission in utero, or is it when, during the time of delivery, when the baby gets exposed to blood?
So that's something which has been, I think, only recently really understood, that obviously there is infection already happening in utero. It usually doesn't, the baby doesn't come out HBS antigen positive, but probably the infection of the cell has already happened in utero frequently, and then probably the liver is not mature enough to produce hepatitis B. So probably then once the liver gets more mature, one then can produce, then the liver can produce S antigen. And then it's probably when the vaccine helps to prevent it, because if you have 1 or 2 cells infected, it might obviously, that the vaccination makes a difference. And one has seen that the vaccination really cuts down the transmission rate. And usually if you lower than 10 to the 8, which would be something like 50,000 copies, yeah, you don't transmit hepatitis B to your baby.
Mary?
So they are, there would have been probably also a nice slide in regard to how diverse the different viruses are. So a genotype within HBV is something like 8% diverse, so A, B, C, and D, while in HCV they are 30% diverse. So they are still relatively homogeneous, so that it's still very surprising that the genotype A is so much more responsive to treatment intervention. It certainly will be very interesting to see, is it really the genotype, or is the hepatitis A genotype, which is usually traveling with a European descent and a sexual transmission route. So if you take into consideration you are not infected neonatally, and then the thing John and his group discovered with a CC genotype for hepatitis C interferon response prediction, it could well be that the genotype is not so important as it looks at the moment. But that will be interesting to see.
Thank you for a very nice presentation. You mentioned something about a liver biopsy, and I wondered if you would just explain a little bit to the group about that procedure.
So liver biopsy is something our patients usually don't like too much, because we need to anesthetize the skin, make a little scratch, and then put a needle through, go towards the liver, and then go with a hollow needle inside the liver and take some tissue out. It's more, I think, someone poking at you than really the actual pain. It's various. Some people have substantial pain from it, but most people actually say that lying on the side for 2 hours on a little bulk to compress is more uncomfortable than the biopsy itself. So that varies. But it is, unfortunately, at this point, still the best method to evaluate how the liver really is. Or next, it's the best one would be doing laparoscopy, but that's usually even more invasive.
How long has the vaccination been out now? How long are they finding it that it's effective?
That's a discussion which is not really solved. It's out since 1980 about. Like in Taiwan, I think they started in 1985, the universal vaccination program. And it seems that even if you decline with your antibody titer, because you have still the memory, your immune system still has a memory function, that you still might be protected. I probably would be more on the safe side than would say I want to have a titer over 100. So probably on an epidemiological scale, people will not be revaccinated, but probably on an scale, if you have a risk, like you work in a liver clinic or so, yeah, you probably should be vaccinated. Or if you dialysis patients, yeah.
Yeah, in the hospital we used to give boosters to the nurses and doctors or staff who had a higher risk of exposure to blood or blood products. So nowadays, I think when your baby's born, and there's been a lot of controversy about vaccinations in general, so for mothers who are negative, so do you think that we should be vaccinating babies when they leave the hospital?
Yeah, I would. So probably it's usually integrated into the month 1 vaccination nowadays, which seems to be perfectly fine if your mom is not HBs antigen positive. And in this recent report where they showed that children from anti-HBC positive mothers contracted HCV, they were still protected from developing a chronic infection by the vaccination in the usual schedule. So.
So from a serological standpoint, when you're looking at a report on a patient, what is the difference that you're going to see in a patient who's been vaccinated versus a patient who's actually had a disease?
Excellent question. That was one of the questions I got wrong when I had my medical exam. And it turned out just...
This is what you call full disclosure.
It turned out that just about a year later I was running a hepatitis diagnostic lab. So obviously I had in the meantime worked up the difference. It's very easy at the moment because the vaccine at the moment is only S antigen. So if you have anti-HBC, you had been exposed to the virus. If you have anti-HBs only, you most likely be vaccinated.
Other questions, comments? We need to invest in a few mics in this room.
Yes, I've just got a quick question. Are you finding that silymarin has any hepoprotective effect on the liver?
That's a very complex question, I would say. So there are some studies, old studies out in alcoholic liver disease where people had seen a beneficial effect. It seems that if you do it, you need really a high dose. At the moment, I don't see evidence-based reason to give silymarin. There are two situations where it might be different. One is, but I think that's probably that's only in Europe. In Europe grows a mushroom which is poisonous and looks very in Central Europe, and it looks very similar to a mushroom in Eastern Europe, which is eatable. So what usually happens in the fall, in the mushroom season, people from Eastern Europe pick mushrooms in Central Europe, eat them, and get fulminant liver failure. And that is one indication where it has been shown that silymarin has a place. The other thing which was interesting is there is a colleague who has a chronic hepatitis C and required a liver transplant and then was on the way on deteriorating with his freshly transplanted liver. And then probably that's one of the issues where you come up with very crazy ideas. And for some reason he had the crazy idea, I try silymarin intravenously, high dose. And after it worked with him, he included, I think, some 9 or 11 other patients and was able to show that silymarin in a very, very high dose, given IV daily, is actually able to reduce HCV. Probably 10 years ago, I would think that will be one of the future treatments. Yeah, with the thing we see coming along with HCV now, yeah, where you get 3 log drops within 2 days. I don't see that that's going forward.
So one of the things that always worries people is, you know, how much of a dose do you need? And we always used to tell people that for hepatitis B, you need a very small dose, you know, a needle stick. And for AIDS, for HIV, you actually need a higher dose. So how much of a dose do you need to actually get hepatitis B? Do you?
Yeah, it's very difficult to estimate, but a good picture probably is if you have 1 drop of blood going into a bathtub, and then you take 1 drop out of the bathtub, that's probably doing the job to get you infected. So it's the most infectious virus which we have around. It's basically another way to see it is that partners of people with an hepatitis B are usually always markers for hepatitis B infection, because at some point in their relationship they contracted HBV but cleared it without symptoms. We then saw a few patients, few partners report they have no marker whatsoever, and we confirmed that in serology. And it's now accepted in Journal Viral Hepatitis that we were able to show that these partners who really don't have any serological marker against hepatitis C, they have actually a cellular immunity. And what would you guess, a cellular immunity against which protein? The surface protein or the core protein? Why do you think the core? Because the core protein, it is actually the core protein. But you can develop a response against the core protein only when you got infected, because the virus has to get rid of its surface to expose the core protein. So that tells us that even those partners where we have believed they have never been exposed to HBV for some reason, they obviously had been not only exposed but infected. So if the reaction is the cellular reaction would be against the S, one could argue they have been exposed but never infected. But with having a core reaction, it's actually that they got infected at some point and cleared it without.
Yeah, and I think when you're looking at households, you remember that, you know, sometimes you pick up the wrong toothbrush. Children will use their parents' toothbrush. People share razors, you know, and so it's not just by conjugal sharing. I mean, within a household, we used to counsel people who were positive also to make sure that their children didn't get exposed to the virus just from normal household contact, you know. You cut yourself and your kid comes over and brings you a Band-Aid. Then they have a small cut on their hand, razors, toothbrushes, you know. There's a lot of sharing in a household. So it's just something to think about when, for those of you who are nurses who are practicing and still practicing in the hospital or meet people. So it's just...
and they should be vaccinated, certainly.
Yeah, exactly.
What percentage of the adult population?
I think there are people on the phone. There are people on the phone who can't. No, it's okay. Who can't hear?
So, like, the vaccine is now part of the pediatric plan, but there's a whole population of us that missed that window. Is it being implemented for the adults?
No, I think from the public health perspective, it's not cost effective to do it. It's that some Scandinavian countries have, for example, opt out on the vaccination program because they say, oh, we don't think we want to vaccinate our newborns because the risk is so low in our country, not considering that they all see immigration from higher prevalence areas. And but adults, it's not planned at the moment to be catched up, I think.
Mary?
For subjects who have hepatitis B and receive a transplant liver, what happens? Does the disease reoccur in the transplanted liver?
that's actually where I would say I started my career with, and we did things which are unthinkable nowadays. But if you saw what happened with HBV, HBV was actually listed as a contraindication for liver transplantation. And nowadays, it's the number one, the dream indication. There's no other disease which has such good outcome as HBV nowadays. The other problem is we don't transplant hepatitis B anymore because we have so effective treatments now. But in the time in between where we started to get better, but were not yet good enough to prevent the need of transplantation, it was actually, there was a colleague in Hanover who developed the idea, let's use passive antibodies. So when you get a needle stick and you have not been vaccinated, what you do, you get passive antibodies. They grab the circulating virus and you usually don't get infected. So he said, oh, that's a great idea. We take out the liver and then we flush the patient with 10,000 units of passive antibodies. Costs about 10,000 units, costs $10,000. Yeah? He did that and said, and then probably we should do it for a week, give them 10,000 every week, every day. And after the first patients doing it in some and not doing it in others, there was no effect. But it has cost probably something like 70,000 per patient. At that time, it was that everything was covered by the government anyhow, and if the hospitals made a minus and the insurance wasn't paying for it, the government came in and took the bill. So that was feasible. This treatment would not be flying nowadays. So then he believed, oh, it's a great idea, we need to do it longer. So that he went for 6 weeks. Bill was 100,000 probably per patient. He saw a slight effect. Yeah? He said, the idea is great. We just have to do it longer. He did it for then 6 months and eventually for 1 year, and the 1 year protocol actually became standard of care worldwide. It was then still that 50% of the patient got a reinfection despite giving passive antibodies. And then we started giving them an antiviral in addition to that. And nowadays, if you see an HBV reinfection in a transplant patient, there was a misconduct. So there was something done wrong. Yeah, because you can prevent HBV reinfection in a liver transplant. And certainly you should use HBs antigen positive organs nowadays. Yeah? No one will die from a hepatitis B infection through an organ transplant nowadays. But people die because they don't get an organ. Yeah? So, and we're thinking that probably about 1% of the population have hepatitis B. If I would need an organ, I would go, give me one. Yeah? And then take one more pill and you don't get a hepatitis B.
Hans, thank you for your presentation. I have a question. I know Susanna Nagy is doing like some really interesting research in HIV, HCV co-infected patients, but I was interested in knowing, is there any like literature in the mortality rate of HBV, HIV co-infected patients versus HCV, HIV co-infection?
Yeah, so I think it's probably that HBV was actually the more nasty one than HCV. I think in the absence of heart, HCV wasn't really doing anything. We did a study where we showed that HCV is only a problem once your immune system comes down. Yeah? And then what had happened is with regard to HBV was always bad. But then you treat HIV and half of the drugs, or the backbone of, or the backbone for HBV, for HIV nowadays is tenofovir plus emtricitabine. Yeah, so that's basically emtricitabine is a little bit, it's like lamivudine, yeah, but then it's the other side of it, the tenofovir. So you have a combination treatment. That's why you nowadays don't see problems with HBV in HIV-infected patients anymore. And also in HCV infected patients, they have a much better prognosis nowadays because you pick them before the CD4 cell counts have been down to 50. Right. Yeah, and HCV is usually a very blunt disease in HIV infected patients who never drop below 500 or 400 cells.
When I worked at Glaxo and I did the studies on lamivudine, we were also looking at it. We called it 3TC for HIV, so we're using the same drug. We were calling it lamivudine when we tried it in hepatitis B patients, but when I did the studies in AIDS patients, we were calling it 3TC. And actually, in the early days of AIDS research, we were waiting until the CD4 counts were really low to even begin treatment. And now, I mean, we didn't really treat anybody until their CD4 count was down at like 350. And now I don't think anybody waits to treat people for their CD4 count to drop to like 250.
Yeah, like I think in our early days of 3TC lamivudine, you barely had actually someone with 250 or 200. They usually were lower than that. Right. But that was because you had resistance and the side effects of the treatment were much higher than it's nowadays. Yeah.
Are there any other questions? So first of all, I wanted to thank Dr. Tillman. Thank you so much, Hans. This was really great. It was fun. It was educational. It was definitely amusing. But most of all, I really want to thank all of you who took time from, I know how busy everyone is and how much I really appreciate your attendance at these sessions. And we'll keep it coming. Thank you.
I think I didn't make my conflict of interest, but it's on the website, and there's not really much conflict of interest besides that my wife works for Abbott.
Oh, there's big conflict of interest, right? Works for Abbott.